my pleasure to turn to our first panel, and I will hand over to our wonderful moderator, Dr. Ruth O'Hara, our chair.
Oh, no problem. Yeah, we are going to have a series of panels today, and I'm going to talk a little bit more to the history of some of the work that we're now doing on sort of combining and blending models of cognition and neurocircuitry to best predict treatment response in mental health. And one thing I want to do is just cast a little bit the history. I believe sometimes understanding our history can be vital in making sure we take the right path forward. So if we go to the next slide, or can I do that? Yeah. I would if I'd brought my glasses. Let me see if I can do that here. Yeah, it's...
You got it.
No, there we go. Yeah. When I started my career, it was 40 years ago, I became a graduate student, almost 40 years ago to the day. And I was very interested in cognition, how people processed information. At that time, cognition in clinical terms was really only considered in the domain of aging, some of which I'm exhibiting very well here and trying to multitask, and also in the domain of ruling out for organic disorders. It'll tell you how long ago it was that actually neuroimaging was really only at the very beginning, and it was not routine to get a structural MRI. In fact, it was not at all routine, and there was no functional neuroimaging. So we often used cognitive tools to rule out for a distinction between psychiatric disorders and what were considered organic disorders. By definition, making sure that cognition was really not encompassed at all in the domain of mental health. Now, we've a vast amount of cognitive processes that this brain is capable of. And over the years, I started to consider, along with some colleagues, that maybe there was more interaction between your cognitive information processing, how quickly you could inhibit information, how you divided attention, what was your memory like, and so forth, and particularly those domains of what we now call cognitive control, executive function. This was augmented by experiences I started to have where I'd see actually cognition maybe more the source of difficulties that were being ascribed to mental health disorders. And one such issue of those sort of interface was I was dating at one point a gentleman who would suggest we'd go to a particular restaurant often for dinner where they never got a steak right. And I remember wondering why this individual would always suggest the same restaurant, even though when we'd go there, usually the steak was sent back and so forth. And if you were taking the psychoanalytic course I was taking at the time as a graduate student, you might interpret that as, in fact, an inability to overcome some steak that had been burnt in his childhood somewhere by his mother. But in fact, what I realized was my companion didn't have a very good episodic memory. I was studying memory at the time. And so I started to become the externalized episodic memory. Remember, the last time we went there, this is what happened. Oh, you're right, let's not go. And it really, that was one of many experiences that I had that made me think, are we ignoring a really fundamental domain by not thinking about cognition? I did go on to marry that person, but that's a whole different story. So we started in my lab, and there were others, thinking about cognition in a as a source or at least a co-occurring disorder with, if you had cognitive impairment, with mental health disorders. And we started looking at depression was the prime one. And I was very fortunate at that time. I was really integrated into geriatric psychiatry. And it was the one place where you could really talk about cognitive information processing as maybe a part of the profile if you had a late life depression, if you had a late life anxiety. We started doing more and more work on this. And parallel work was being done with schizophrenia, another domain where we really started to recognize in the 2000s, the early 2000s, the interaction between cognition and psychiatric symptoms. We found that they were associated with, indeed, poorer cognition was associated with depression and anxiety in late life. But what we started to see was actually a slightly different profile. While in fact memory dysfunction and executive dysfunction were key to depression, we found that actually inability to inhibit seemed to be a hallmark of anxiety. And that actually mapped onto some models of emotional inhibition that were being developed by Amit Etkin at the time that I started to focus on and actually persuaded him to come to Stanford too. We also started to realize this is not just a phenomenon that occurs in older adults, it also occurs in younger adults. Nobody really does a cognitive profile assessment for individuals who are younger with depression, but that has started to occur, particularly in the last decade here since 2010. And we've started to see, in fact, as well, the association of certain types of cognitive deficits with suicidal ideation. We really started to build a model here, and we started to deconstruct the emotional inhibition and suggest that, in fact, that's observed by deficits in working memory and information processing speed. So lots of work to be done. And it resulted in 2013 with Etkin and myself writing a paper that many of the neurocircuits that are involved in cognitive information processing, particularly in the prefrontal cortex, overlap with the neurocircuits that actually had been identified and starting to be identified as associated with certain mental health disorders. This soon became of interest to those predicting treatment response, starting again mostly in older adults. But Josephine down at Washington University, now at Penn, did a beautiful paper where she looked at SSRI treatment response in late life depression and found that hippocampal volume, structural, was definitely a predictor of poorer response. If you were actually had a smaller hippocampus, that you had actually a less effective response to the SSRI. But she also found that an independent marker of treatment response was speed of information processing. And people who had already started to slow in that domain were also independently identified as poor treatment response remitters, so they did not really respond well. So we started to think that cognition could very broadly start to predict treatment response. But like so many things in our science, we discovered very quickly that this wasn't the case. We did a study that we looked at executive dysfunction in individuals with late life depression who in fact were undergoing cognitive behavioral therapy. And our prediction was 30% don't respond to CBT in late life, and 30% have executive dysfunction. These are one and the same. We found exactly the opposite. The individuals who improved most in their mood were actually those who had worse executive function. And we replicated that with problem-solving therapy. And what we thought was probably happening is that therapy itself was a scaffold for the cognitive impairments, particularly in organization and sequencing, that these individuals were suffering from. And so we are following up on that work. The story was much more complex when we looked at neuroimaging. We had actually fMRI pre-treatment with the CBT. We saw some patterns of treatment response, but sample size was small, very limited ability to actually see were there different patterns. And we saw too many different patterns predicting both response and lack of response to be able to make much sense of it. And this is one of the topics you're going to hear about today, where we'll actually talk about how do we use AI to capture that complexity that so far has not been something we can do. Leanne then brought an extraordinary vision to us. She said, look, we already have these wonderful circuits that have been identified from the default network circuit through our salience networks. These may actually be circuits that already can give us more predictive value, particularly if we start to use them in interaction with cognitive measures. So building upon this seminal work published in Lancet in 2016, it sort of gave us a more defined start and base. And really some of the work that's come out of that has been tremendous, where Leanne has been absolutely a world leader in this work. Her and her team have started to do this more stratified prediction of treatment response. And in addition, in integrating this into our own models, we see that other disorders. Here is actually work that we did in 2019 on predicting treatment response from exposure therapy for individuals with PTSD. The neurocircuit is effective at predicting, but not near as effective as when you combine it with measures of memory function. So we're starting to get a sense that although we could establish a more streamlined base, we really are actually dealing with very complex information. The relationship of cognition and neurocircuits to predicting treatment response depends on the treatment. You have executive function associated with poorer response to biologic treatment like an SSRI, but better response to CBT. You have different populations where different cognitive measures are more involved. It was memory and not of executive function that was the best predictor for our patients with PTSD. But as our recognition of the vast amount of data, the vast number of neurocircuits, the vast number of cognitive measures, the vast number of treatments increases, how do we tackle this? I go back to feeling overwhelmed when Leanne said, no, we got this. So, you know, the other thing I just want to mention here is that if cognition plays such a seminal role and is so integral to our treatment response, we can do things about cognition to improve it, and about emotional cognition, such as inhibition for emotionally valenced material. And so we've been doing work in this domain. But there are so many different modes to capture, so many dimensional approaches, and across the lifespan. What is the case when you're 20 may not be the case when you're 40, may not be the case when you're 90. And so really the model for going forward is to make sure that we're connecting these dots. And you'll hear on that shortly, that make sure we're bringing the multiple domains together. It was almost sort of considered odd to mention cognition way back in 1990 when one was trying to get it considered in the domain of mental health. To actually have the facilities that Leanne has outlined today. And then I think the new secret sauce is the state-of-art data science and AI approaches. As David Entwistle so eloquently spoke, this is a domain area where everyone knows that it may be the solution, but not a lot of people know how to use it or even to understand it. I feel in mental health, there's no excuse for that, because most of us have had very rigorous training in statistics of all kind and Bayesian models because of the need to have those in the absence of more objective data. We have a perfect marriage of data, of approaches, of tools, and of more objective measures from our new brain imaging, including externalizing of neurons via induced pluripotent stem cells. I think, Leanne, now is our moment, and I'm going to hand over to you to actually do the next talk. Leanne is going to talk about scaling and how important that is for reaching the next step. Thank you so much.